Welcome to today's webinar. The topic for today is wheelchair seating and positioning techniques to promote engagement in long-term care. My name is Kelly Sullivan and I'll be hosting today's presentation. As a reminder, this webinar is intended to provide general information, but not legal advice. We have a great expert joining us today and I'm honored to introduce her. Brenda Mahon has worked in the field of occupational therapy since 1997. Throughout her career, she has mainly worked with the older adult population in skilled nursing, assisted living, and home care settings. Her focus has been on seating and positioning and managing acute and chronic conditions. Additionally, she has 5 years' experience as an adjunct professor, teaching practice skills, emphasizing the mature client. As a lifelong learner, she hopes to guide other therapists, students, rehab directors, nurses, and administrators through educational guides, blogs, webinars, and live courses as Broda's first clinical education manager. Brenda, I'll now turn it over to you.
Hey, Kelly, thank you. So welcome, everyone. I'm very passionate about seating, especially in long-term care. It's important for anyone who's a wheelchair user, but very important for long-term care residents. So here are the objectives for today. So everyone should understand the key aspects of seating with the focus on the long-term care environment. And I realize that there are administrators here. There's a vast audience, so that's great. So if you're a therapist, a lot of us already know these things. It's a good way for administrators and nurses to understand how therapists look at seating and positioning. So understand the importance of achieving the proper fit and comfort between the seating system and the patient. Determine the factors of selecting the appropriate cushion or seating surface, because some seating surfaces don't really need a cushion. And learn how to apply seating and positioning principles to achieve optimal alignment and comfort so that it'll support engagement in life, basically. So I'm an OT, so everything we engage in, all our occupations are what we call life. So why is seating and positioning important in long-term care? Again, if we need a wheelchair for mobility and to get around, it's really important for quality of life to have the correct fit and to have the appropriate equipment. So according to this systematic review, it was 2017, so that was pre-COVID. So I'm sure the results are a lot grimmer today. And one study stated that over 70% of skilled nursing facility residents spend a good portion of their day in a wheelchair. And I would venture a guess that it's even greater than that. I think it's, I don't know about you and where you've worked, and I worked in a couple of states, but it definitely seems like more than 70% of our residents are in the wheelchair and spend a good part of their day seated in a wheelchair. And I don't know when it happened, but I always say in long-term care, we became like Oprah, right? Everybody gets a wheelchair. So once they're admitted, when they're admitted, we don't really know them yet. So it's possible something precipitated them coming into the long-term care environment. Maybe they were hospitalized. Maybe they had an acute injury or needed some type of surgery. Or maybe they had a decline. So a lot of times in the beginning, that's appropriate. What I have noticed over the last few years is, we're all in this together. It's an interdisciplinary team, right? I've noticed that we're not that great at taking it away from some people. So for some people, if they need mobility for long distance, that's great. But I remember the days when we actually used to do walk to dine, or we had other programs where at the very least, we were getting people out of their wheelchairs and getting them to sit at the dining room table instead of having all their meals and spending their entire day in the wheelchair. So for my therapist friends, I challenge you to think about those things. So more than 1 in 10 nursing home residents have a pressure injury, and stage 2 is the most prevalent. Now, these statistics are for 2009, and again, pre-COVID, and I'm sure they're a little grimmer today, especially after COVID and during COVID. And now let's face it, a lot of us are facing staffing shortages. And I know we're fighting with CMS right now about nursing home staff ratios. And a lot of you are probably dumbfounded. We can't even find staff, right? So what's going to happen if they enforce that? So we definitely have a lot of challenges in the long-term care environment. So seating and positioning, it's an important component of providing quality of care. It's important to understand that one size does not fit all. It's a skilled service. So this is why when sometimes other disciplines may not understand why we can't just give Mrs. Jones, everybody's Mrs. Jones or Mr. Smith, a cushion and call it a day, or a different chair because they're having trouble. It is a skilled service. It takes an evaluation. We have to look at a lot of factors. We can't just issue another wheelchair or another cushion and call it a day. There's a lot of things we have to look at. I always call it like Jenga, right? Because you can take one piece away and think you're doing really well, but then it causes a domino effect with something else. So again, it really is a skilled service, and it takes a little time to find the right system for each individual person. And proper fit is really, really important. And we don't talk about comfort enough, but comfort's very important. Now, hopefully they're not teaching this in school anymore. This is what I was taught when I first was in school, right? 90, 90, 90. And looking at those lines. Now, I don't know if you've noticed, but I'm already been shifting in my seat, and we've only been on this webinar for a little bit of time. So think about our residents, especially those that are like mod or max assist or dependent. You know, a lot of them cannot wait shift. They can't wait shift on their own, and they're not comfortable, and they can't even move to redistribute their pressure. So that's why sitting, I always call 90, 90, 90 situation. It's kind of like wheelchair prison. We can't take someone who's lived a life and been active and maybe have injuries, have arthritis, and have other comorbidities, and try to get them to sit at those angles, because we're going to fail. So when do we screen for positioning? Well, again, anytime anyone's admitted, anytime there's been any significant change is a good time to look at it. Look at someone's seating and positioning. If they're spending too much time in bed, if they just returned from the hospitalization, right? These are all times to look at it. Or if they start isolating in their room and maybe they're staying in like their reclining regular furniture chair and not getting out of the room. These are all reasons we would want to take a look at their seating. So what should be assessed during a seating evaluation? Well, it's just like when you bring the car to the mechanic, right? If you go for an oil change and your tire's falling off, they're going to tell you that there's something wrong with the tire. And it's kind of the same thing when we do an evaluation for seating and positioning. We're actually looking at a lot of things because we don't do evaluations in a silo. We are always going to be looking at the usual suspects, right? The comorbidities, the function of that patient, the prior function, what's their function now? What's their skin like? What's their cognition? And we'll talk a little bit more about that in a bit. So here's when it becomes challenging. It becomes challenging for that patient that might be mod, max assist, or maybe they're a mechanical lift to get out of bed. We cannot skip the mat evaluation. If we're going to do proper seating and positioning with a patient, we really need to get them on the plinth or the mat. At the very least, we need to get them in a chair that's not a wheelchair, like a harder surface, so that we can see how they truly sit. We need to see what they look like. Can they sit? Are they hands dependent? Do they need their hands when they're sitting? Otherwise, maybe they don't have the trunk control. They can't keep their balance. What does their body look like? We could really only see if they have contractures or postural abnormalities, whether they're whether we can accommodate it or not. We can only see that if we get them on the mat. So we're going to talk about the usual postural abnormalities that we see in long-term care. And I always say, if we're going to put everybody in a standard like sling seat type wheelchair, if they don't have postural abnormalities going in to the chair, if they sit in that chair long enough, they're going to get them, that's for sure. So the anterior pelvic tilt is generally It's not as common as the posterior pelvic tilt that we'll talk about next, but there's a growing concern with obesity in this country, and obesity is one of the contributing factors to this posture. Poor abdominal strength. You're going to find core strength and poor abdominal strength behind a lot of the postures, or they have something to do with them for sure. And tight hamstrings might also contribute to the posture and other abnormal postures. And I think about men. A lot of men have tight hamstrings naturally. Here's a hint: it doesn't get any better when they get older. So the posterior pelvic tilt is the bane of every therapist and administrator and nurse's existence, right? Because we've all seen patients slump down in their chair. And this is that one posture that causes wounds for sure and can often lead to falls, right? It's when they're kind of sliding out of the wheelchair. It's the most common culprit is poor core strength, tight hamstrings. Then they get that forward flex posture, and a lot of times it results in that downward gaze. So again, when someone sits in that posture for long enough, they can start to shut down and get socially isolated. There's so many things that we don't really think about when it comes to how abnormal posture can affect someone's quality of life, and why it really is important to get the seating and positioning correct for anyone who's in a wheelchair for hours a day. Other things that posterior pelvic tilt it can cause difficulty with propulsion. It's hard to try to propel a wheelchair if you're sliding out of it, right? So it's also very uncomfortable, right? They're sitting basically on their pelvis, they're sliding forward. Now, there are things we can do. Some patients don't need something really aggressive. I think about, let's talk about Mr. Jones. He sits great in the beginning of the day. He's sitting upright in the chair, and then you walk past him a little bit after lunch, and then he's starting to wilt a little bit in the chair. So for someone like him, that maybe he's still mobile, he can assist with transfers. Maybe for him, we could get a cushion that might have, like the saddle type cushions they make with the slight abductor wedge that has a little sacral cutout, or an anti-thrust that's not really aggressive. Might be enough. Something that'll take the sling out of the seat if we have them in a standard wheelchair would be helpful too. Or tilt, and we'll talk about all these things in a little bit. But the one goal for all these postures, and one thing I want you to always think about, if you don't take anything else away today, especially for our patients that require a mod, max assist, or those that are on a mechanical lift, the more contact the patient makes between the system and themselves, the more comfortable they're going to be, the better pressure redistribution there will be. If it matches their contours, we're going to be in great shape. It's going to support them throughout the day to be able to participate in activities that are important to them. So pelvic obliquity, some of the causes are scoliosis, or somebody maybe sat as post hip surgery where the post-surgery side is higher than the other. Sometimes it could be a cushion incorrectly placed that makes it look that way. So just like you always make sure your computer's plugged in before you say it's broken, same thing. Always want to check the equipment and make sure that the equipment is set up the right way, right? If the obliquity is not fixed, so in other words, it's not a contracture, we can add a wedge to the low side to equal out the pelvis. That's the other thing I want you to think about. The goal of all positioning is going to start at the pelvis. The pelvis is the cornerstone. Sticking pillows alongside of someone is not going to fix their pelvis. So just remember that. That's another reason I'm bringing that up, and it's important to remember. Everything starts at the pelvis. The goal is always to get the pelvis as close to neutral as we can, and then we can go from there. So that's an important thing to remember. Now, when I'm talking about adding or subtracting things to even out a pelvis for an obliquity, we're not talking about a MacGyver move here. We're not going to take some random object. Therapists are good at doing this, so that's why I bring it up, and stick it underneath the cushion, because that's never going to work. They actually have cushions that have obliquity kits. That's something to consider. And then there's always custom molded, custom seating. That's another option. But for some people, they could maybe use a cushion that comes with an obliquity kit. So that's something to consider. So if an obliquity is not corrected or accommodated, it can increase the risk of the pressure injury since the pressure is concentrated on one of the ischial tuberosities. And it can also place pressure on the rib cage. So if we don't accommodate this, if we don't fix it and get the pelvis as close to neutral as we can, it's not a matter of if we're going to get a wound, it's a matter of when. Windswept deformity. Believe it or not, you can take a look at this picture here. Windswept deformity can occur sometimes just being in the wrong chair, right? And then if you sit in the wrong chair for long enough, if it's too big, right? If someone's sitting in a really big chair, they start to get tired because the chair is not supporting them. They can lean into this posture and you could actually create an abnormal posture, such as a windswept deformity. And if you look at this setup right here, it looks like the chair doesn't fit correctly. But another important thing I want you to remember about this posture is do not use elevating leg rests for this posture. And the reason I talk about that is I used to think as a therapist, I used to order elevating leg rests with all the chairs that came into the long-term care facility. I thought it was such a good bargain. I thought it was great, right? Raise the legs up for edema, which unless we get the legs up over the heart, it's not going to help with edema anyway. And that's really not the answer. It's going to exacerbate the posture. So for a lot of people, unless there's an orthopedic condition, there are reasons to use elevating leg rests for sure. But there's a lot to be said about, that's why proper positioning is really important. Some people just need the foot rests. So that's another thing to consider. So what happens if we leave these abnormal postures and we just go on about our day and we stick pillows in and we try to accommodate the best we can without really getting the proper equipment? We're going to start to have problems. We're going to have decreased respiration. It's going to affect someone's swallowing. It's going to affect pressure injuries. It's going to lead to falls and contractures. Eventually, it's going to lead to isolation. Or the person's not going to want to get out of bed. Because if you're not comfortable, are you going to get out of bed? Now, here's another older statistic, followed by some that aren't as old as the original one, but 1,800 deaths annually attributed to falls in skilled nursing facilities, right? So poor seating and positioning can absolutely contribute to falls. And a lot of times people fall because they don't lock their brakes, right? That's another thing to think about. I cringe when I think about how much it must have increased all the falls during COVID and how many unwitnessed falls that we probably had, right? So another thing to consider. And do you want to sit there? This chair right here. So this is actually a chair. I probably took a picture of this about 15 years ago in a skilled facility that I worked at. And I would love to say that those chairs don't exist anymore, but they do. I've seen them. That is so old. It actually has fixed armrests, and you can't see the footrests are fixed too, which is great because, you know, if you don't kick them up, someone's going to trip over them. So it hammocks, and over time, and just the hammocking alone is going to create that internal rotation and that abnormal posture. It's going to also increase kyphosis in the back and encourage that kyphotic sitting. And if you think about what I said before, when you have somebody who's sitting with a posterior pelvic tilt, so that's when they're kind of slumped down in the chair, they're not making good contact with their system. The only thing that's making good contact is the sacrum and the scapula. And that's generally where those wounds will occur if you leave somebody in that posterior pelvic tilt for a while. Now, people used to always say, and I used to hear this a lot, that the nursing home just has to supply a wheelchair for the person, right? That's all that's medically necessary. But I challenge you to think about the Impact Act, right? Because if you think about seating and positioning, 3 out of 5 quality measures actually fall into seating and positioning, right? Skin integrity is one of them. If you're not sitting in the right system, how are we going to prevent a pressure injury, right? If we're sitting in an abnormal posture. Or if someone already has one, how are we going to make it any better, right? That's part of the Impact Act. And then what about the functional status of the person? If we're not sitting in the right system, their functional status is absolutely going to be negatively impacted, right? For sure. They're not going to be able to do their ADLs efficiently. They're going to stop wanting to do them if they're difficult to do, right? Whatever they might have done before, they're not going to want to participate in if it's harder to do. And then what about falls? So falls are also another one of the indicators. So all three of those can be directly related to the Impact Act. So if you're not sitting in the proper system, we really need the right fit and the right support to provide the optimal pressure, to give you the pressure redistribution, to prevent the falls, to prevent the pressure injuries, to prevent the contractures, right? So just something to challenge you to think of. And when I bring this up, it's November already. Start thinking about next year's budget. I always say, you know, if you schedule it out, or for my therapist friends, bring some solutions to your administrators. Don't just bring them, we need new chairs. Do a little homework and tell them why. Or tell your DOR to do a little homework and tell them why you need new chairs, right? Tie it into the Impact Act, the things that are important, and how we can change our star ratings by making patients more comfortable, getting them to engage and getting them to participate in their life, right? So maybe you make a budget for 5 or 6 better chairs for next year. Maybe you make a budget for a couple of more cushions, add some better cushions into your toolbox. And we'll talk about cushions in a little bit too in seating systems. Jerry chairs. So they're not really for support. They're not for positioning, that's for sure. If you've ever sat in one, they're pretty uncomfortable. They're not very supportive, and they don't offer good pressure redistribution. And the worst part about them is they're recline only, and a recline only system can lead to shear. So we always talk about pressure injuries, pressure injuries. Usually with a pressure injury, we have a little bit of a warning that one's occurring, right? People will start to have a little redness, maybe a little pain. There's usually some type of indicator. The problem with shear is shear's insidious. It occurs in seconds. You know, you think about that person that starts sliding down in the wheelchair. That's when shear occurs. And it happens in seconds. And before you know it, it already went through all the skin layers. Now, I get it. I've worked in quite a few facilities where this was the premier chair. But if you look at this reclining chair, and it is appropriate for some people, I used to use it a lot for my taller, maybe status post hip patients, right? My taller gentlemen could open up the seat to back angle a little bit so they'd be a little more comfortable while they were recovering. But at the end of the day, it's just recline only. Again, same thing. I'm talking about the shear. And it's also still a sling seat. So we can definitely do better. Like a little tilt can make all the difference because it's going to assist with your postural alignment. It's going to help with, it's going to decrease fatigue, and it's going to improve comfort. Excuse me. And if you have a forward-facing tilt, you'll still maintain line of sight while you're propelling. So here's my little joke slide, but not really a joke. So think about your budget next year. And we're going to talk about components of the seating evaluation. So like I said, we are going to look at all the usual suspects. We want to know what the person's skin integrity was like. We want to know what their ADL history was like. What did they used to do for themselves before? What's vital and what's most important is we want to know from the patient what's really important to them and what they want to do and what they want to accomplish every day. And that's where we get our cues for the type of seating system we want we want to get them in, right? We want to know what they want to do every day. We also want to look at their muscle strength, right? We want to get them on the mat, like I said before, so we could see if there's any postural imbalances, if there's any contractures or muscle tightening. We want to see how they perform their ADLs if they're going to be sitting in a chair. How do they transfer on and off the toilet, right? How's that happening? What's their strength like? Now, as an occupational therapist, I used to use, of course, I used goniometry, but I always used manual muscle testing as appropriate. And I always used dynamometry because you can really tell a lot about someone's general overall strength by testing their grip strength. And their grip strength is actually tied to mortality. And it's a good indicator when somebody's getting better, right? Now, of course, it's not going to work for someone who's got severe osteoarthritis or nodules in their hands, or maybe they have a Dupuytren's contracture or something like that. But generally, overall, for a lot of people, it's going to give you a lot of valuable information about their strength. We don't want to overlook cognition either. So another thing to think about. Sometimes people have slid under my radar where I thought they were better cognitively. They just smiled a lot and seemed to laugh appropriately, I guess by watching facial cues. So a lot of times I wasn't so sure about how they were able to propel their chair. So another important thing to remember. And these days, let's face it, a lot of people that come into skilled facilities generally have some type of cognitive impairment, whether it be mild or, right, we're right up to mild to severe cognitive impairments. So really important to know. Some seating and positioning goals. We want the patient comfortable, right? So that they'll get out of bed. Now, every facility I've ever worked in has had a few people that just never want to get out of bed. So there are some people that are truly non-compliant, right? They're just their thing. But I like to always give everybody the benefit of the doubt and talk to them about why it is important to get out of bed. We have to consider how'd they end up there. Again, did we put them in one of those 90-90 wheelchair prison situations? And then maybe we sat them up for like 2 hours. Maybe they rang the bell. It was that change of shift, or it was after lunch. And they just got into a place where maybe 2 or 3 times they couldn't get back into bed after a while of sitting and not being comfortable. And then they got into bed and they said, that's it, I'm never doing it again, right? It happens. It happens. So if we get comfort right from the beginning, we'll have a lot less of these types of situations, right? So for that person, especially for someone who is MOD, max assist, we want to make the best kind of connection we can between them and the system. And then for our other patients, we want to make them mobile, right? We want to make them mobile. In order for them to be mobile and want to be in, to participate in activities, they have to be comfortable. So that's another thing we want to consider. And then we want to prevent and decrease the risk of secondary conditions, such as pressure injuries, skeletal deformities, and such. Again, I used to be a big proponent of wanting, like the independence police, trying to get everyone to propel themselves everywhere when I first got out of school. You have to remember that it's mobility, it's not an exercise. So if it's not important for that resident to push themselves all over, like we have to listen to them and what is most important. There's also other ways to propel that's a lot more comfortable and takes a lot less energy, right? There's things we can consider here. Foot propulsion, you have to have a low enough seat to floor height, right? That can save shoulders for sure. Or front mounted mag wheels. I think I have pictures of that for you. The other thing we definitely want to talk about here is whenever you are going to buy some new wheelchairs to add to your tool chest to have better options, you want to look for as much adjustability as you can find. The bane to my existence for many years, especially with a lot of petite women, right? Because no one gets taller when they're older, for sure, right? The average wheelchair it's usually between 17 and a half and 19 and a half seat to floor height, right? So maybe you have like 2 inches of adjustability. Think about a chair that maybe 12 or 14 inches seat to floor height. They used to call them like low or super low hemi chairs that maybe has 5 inches of adjustability. Think about how many multi-use situations. So that can accommodate, like give almost a custom feel to a lot of different residents. So the more adjustability you have, like adjustable armrests, different types or adjustable footrests, and adjustability between seat to floor height, you can accommodate a lot more people. So that first picture had that mag wheel in the front, right? So that's great because the person's not reaching all the way behind themselves to propel. So that helps with the shoulders. It's a better biomechanical alignment. The second half of it has the 4 casters in the front. So those casters are great if you think about somebody with cognitive deficits or somebody that has dementia that might be a little restless, that really is not a good ambulator anymore, but keeps trying to get up from the chair, right? Keeps trying to walk, even though they might not be able to without assistance anymore. Are we going to take that person that's walked forever, that never used a wheelchair before they had dementia or some type of cognitive deficit, and try to get them to use a wheelchair and try to get them to make the coordination to propel the wheelchair? Is that going to happen? You're going to have as much luck as you have for that same patient that just needs a walker after they have a cognitive deficit that never remembers to take it. So it's just another tool in the toolbox. Maybe 4 casters are the answer. You have a low seat to floor height, and that kind of mimics walking. So that could be the answer for someone really restless. And again, as therapists, we would love if everything worked for every person and we had the magic, the magic cure. So that's why you need a lot of different tools in your tool belt, different things you can try. So things to consider when you're starting to get new equipment and adding some new equipment. These are just things you'd want to think about. So the environment is another important consideration when we talk about wheelchairs. A lot of skilled facilities, there's not a lot of room inside the residence rooms, and especially inside the bathrooms, right? So that's another consideration you want to think about before we make a lot of changes, and that's one of those Jenga situations I was talking about, right? I've seen it happen a lot with women where maybe they're crammed in an 18-inch wheelchair and they could really use, because they've gained some weight, because they came from home, they weren't getting by themselves, maybe they weren't cooking anymore, they had a cognitive deficit. And then they come to a facility, they're getting 3 meals a day that they don't have to worry about. It's just they get fed. They've gained some weight now. Maybe now they need, let's say, a 22-inch wheelchair, and they're crammed in that 18. If they're able to get on and off the toilet, let's say with mid assist, and that 22-inch is going to keep them from navigating the bathroom, we might want to split the difference, right, and get them a 20. So these are things you want to consider with the environment. This is sometimes where maybe casters would work better navigating the environment, especially if someone has a cognitive deficit or a strength deficit, or they have bad shoulders and they're not able to maneuver around their room so well. So these are just things to think about when we're doing evaluations and thinking about equipment. So we're going to talk about cushions a little bit. There's basic cushions. There's a whole bunch here. The great news today is there's so many different kinds of cushions out there. There's so many different types. There's stuff for positioning. There's stuff for pressure relieving. There's stuff that has a little bit of all three, right? Offloading. And then there's still always the option of getting some custom seating. But there's a lot of great options out there today. Here's some properties you want to look at for your seating surfaces, for beds too, honestly, for any surface, any type of surface. You want to think about immersion. That allows the body to sink into the cushion or the surface, right? Again, there's seating systems out there that don't need cushions that offer immersion. Envelopment, that's when they sink in and it actually conforms to the patient's contours. So that's another property to look at. Offloading, right? That's where we're going to take, that's when you have that little dump in the back of some of your cushions that might have a gel pad or a cutout in the back. Those are all properties you want to look for in your seating surfaces. Your pelvis there, my little pelvis that I put in that cushion. I had the cushion cover off so that you can see what I'm talking about there. So that actually showed immersion and envelopment. So when you first see the cushion, the pelvis sink into the cushion, that's the immersion. And then when you see it kind of follow the contours, that's the envelopment. So those are the properties that I'm talking about. And if you see on that cushion too, there's a little bit of an abductor wedge and on the top. So it offers the positioning as well. Different materials are going to accommodate the body's load in different ways. And what works for some people aren't going to work for other people. So it's another thing to think about. That honeycomb style that's over on the left, I used to be a fan of those. I wish a lot of places would have, for low, like that one's got a very low profile. That might be really good. It's much better than having the foam cushion that someone sits on and they bottom out, right? I always say that buying a lot of inexpensive foam cushions that bottom out is really not saving you any money. I think therapists are a little bit to blame to think that it's a good deal because we're afraid to throw anything out. And those foam cushions or those inexpensive cushions, they live way past their expiration date. And you know what I'm talking about. The stains, the smells. If you walk into your closet where you keep that stuff and you want to pass out, it's time to change that stuff out. I do, like I said, I like that honeycomb style, but I can tell you works for a small population of the older adults just because it is a very firm surface. It's kind of made of the polymer urethane. So for some people, it's too firm. So there's that inexpensive foam cushion I was talking about. So I always say something like that. The only person I could see sitting on that type of cushion in one of those sling seat wheelchairs is someone who is mobile. Maybe someone that needs a wheelchair for distance, maybe to get them to the dining room. They're still able to weight shift. They're still able to transfer with or without some assistance. Maybe those people. But for everybody else, we have to do better. So here's another type of cushion that gives you some mild positioning. It's got some position. Again, the covers are off so that you can see these. It provides gel for the bony prominences. It has some contours to help you with the posture, right? It's got that little abductor in the middle. And for some people that have a posterior pelvic tilt, that it's not a, it could work. They don't need something really aggressive. Here you have one that has a fluid sac in the back, has a little bit of an abductor wedge. And then think about, so something with that type of foam will take some sling out of your seat. So there are some things you can do to make some of your sling seat options better. Again, we're still talking about your patients that can weight shift, that can transfer, right? Because I wanted to talk about putting a lipstick on a pig, but I don't know. I might be showing my age there. But anyway, I talked earlier about a positioning type of kit and doing an obliquity. So something like this would work excellent. That actually has a kit. If you see on the top part of the cushion over that fluid sac, that's something you could use for pelvic obliquity. It goes underneath the cushion, but it actually Velcros to underneath the cushion. And I always say if you're using an abductor that high, the one that's on, well, it's on the left of the screen for me with the little gel in the back, start over. If you need something that high and aggressive, you're doing the wrong thing. And then there's that cushion on the right. It just shows you the fluid sac in the back that has a little bit of a dump. Excellent for positioning and offloading. And today they have smart cushions. That one in the middle is actually an alternating air cushion. We've come a long way with all types of different cushions these days. So it's an exciting time to be a therapist. The only thing I would say about the cushions with the higher cells, the 4-inch type cells, if we're going to use those, and that's what you have for your stage 3 and better wounds, let's make sure we're teaching everyone how to maintain them. right? We can't just put it under somebody and call it a day. Another thing I want to mention, DISM nothing should go on top of the cushion cover except for the patient's bottom. Okay, you're going to say, what about the sling for the Hoyer lift? I did just see, I don't want to say Hoyer's a brand, right? But for any kind of mechanical lift, I did just see an article recently that said they're kind of negligible. They don't do, it's not really a bad thing to have the sling underneath somebody. And here's what I want you to think about when it comes to that. If it's going to take so much finagling to get the sling in and out, we're talking about shear again, right? And if that person can't really help you position, right? They can't because they need a mechanical lift. So think about the pros and cons there. You're probably going to do more potential damage by trying to finagle with that lift sling than if we just had the sling on top of the cushion. So just something to consider. DISM never belongs underneath someone's bottom. Never. Because the coefficient of friction for DISM is really high. So what that means is no slippy at all, right? So unlike polyester pants that slide all over the place, that's what's going to cause shear. You know, a lot of people used to think that used to work, keep somebody from sliding. It doesn't. The person's still going to slide, but now their pelvis is sliding underneath their skin. So that's just going to cause shear. No Chucks pads. I know our CNAs love them. They're the heroes of our facility. They can't put those on there. They're trying to save the cushion from being incontinent. We need to order 2 cushion covers for every cushion we buy, right? So that we have an incontinence cover. Just say no to the pummel. The groin is not a weight-bearing surface. Please remember that. I always say that. It's important. And then I talk about the donut cushion. A lot of times those are our patients that bring those in, right? Their family members bring it in because this is what they always used. Really, if you're going to use a donut cushion, it should just be for hemorrhoids. It just creates a lot of pressure around the border. It's not going to offload. It's going to create pressure all along the border. So just say no. Just say no to those. Wounds and cushions, we always want to think about the etiology of the wound. Someone might not have gotten the wound from being in the chair. It might have came from the hospital. It might have came from the bed. We just have to work with what we have and understand how we need to accommodate it to prevent the wound from getting any worse, right? That's what we want to do. What about the back? For years, I thought I was doing such a great job by getting everybody these high-end, wonderful cushions. And then I forgot about the back. Guess what? I was only doing half the job. The back is just as important. If you leave the sling seat back and you get a really high-end cushion, we're still going to get that kyphosis in the back. We're still going to have abnormal posture. It's still going to put all that pressure on the scapula. They make a lot of different backs today. Contoured, you might need something aggressive. Just like the cushion, you might not. You know, you might be able to use something a little plainer than the contour. But again, a lot more comfortable. Look at the gentleman on the right. Look at all that pressure redistribution that he's getting there. And that little bit of tilt is helping him with his posture and fatigue. And he's able to propel with that foot. So there's some more backs for you. Again, contours, anytime they're going to match the client's body, we're going to have a lot more contact because that's the name of the game today, right? It's going to result in great pressure redistribution. It's going to be a lot more comfortable. Funding. So when you're in a skilled facility, usually if you're in a state that has some fundings, there's a handful of them, right? There's probably like 12 states that still offer some funding in skilled nursing facility settings. And generally anybody on this call that has some funding for their patients in their skilled facility knows, right? So the other thing I challenge you to think about though too is Medicaid spend down. That's another really good opportunity. Instead of getting Nana the, I don't know, 100 square foot TV, right, from Walmart, maybe they get a good cushion and a smaller TV. They don't probably need, maybe a little less expensive TV. They'll get a lot more use out of a really good seating system than a giant TV. we could get a smaller TV. So that's a good thing to think about. Restraints, we don't see too much of those, thankfully, as we used to. I do want to mention there are times, though, when a positioning belt, like for your anterior pelvic tilt, that can be all that person needs. It just has to be care planned. That is for position. It's positional. Sometimes you got to start thinking outside the box a little bit. So luckily, restraints are not as big a deal before. So I'm just going to run through this really quick. Martha with Parkinson's disease, she was referred after a decline in mobility and ADLs. She used to participate in her ADLs. She used to like to go to the knitting club. Nursing started reporting she wasn't going to knitting club. Matter of fact, she wasn't really getting out of bed, and she was sliding out of her chair. She had no fixed contractures, and she was really uncomfortable and starting to get a sore bottom, and she couldn't tolerate being in the wheelchair for more than 2 hours. So, sounds like a lot of patients I've seen. So there's Martha, right? So that doesn't look like fun. So what are we going to get her? Something like I showed you before, maybe a tilt, maybe something with contours that are going to match her body, right? Something that's going to give her good pressure redistribution. Why? Because we want to change her life, right? One chair at a time, one person at a time. So just to review, client preferences, really important. That's number one. We want to know what they want to do with their system. We want to know what their functional level is like. We want to know what their comfort's like. We want to know their balance, their muscle tone, their strength, everything. And then clients' preferences. Why is it's in the beginning and the end? Because that should be the be all end all. We really want to know what's important to the client. So to summarize, an affecting seating intervention, it should be comfortable. It should increase or maintain function. It should decrease the risk of pressure injury, falls, and contractures. It should change that person's life. And we do that one chair at a time. And I really, truly believe that. Thank you. Thank you for your time today.
A huge thank you to you, Brenda, for your expertise. We'll now be moving into the Q&A section of our webinar. Using a pummel cushion is now considered a restraint at some places. How would you approach to not be a restraint and still use a pummel cushion, or is there another way to achieve the same goal?
So I'm a very big advocate of no pummel cushions. Now, I have had some therapists tell me that, I mean, unless it's for the intended purpose of someone that is strictly for hip precautions, maybe they have dementia, they don't remember they're a leg crosser. So I don't want to take that off the table. But for anyone else, there are so many other options out there today. Again, it's going to depend on that person and what they're doing. So they might need a little bit of a sacral cutout in the back of the wheelchair with a slight abductor wedge. That's why getting one of those obliquity kits would be a great investment for your facility, because then you could try different things. That could be your kit, and then you could order what you need with that. So am I allowed to mention any names or no?
I think that
I know there's one. If somebody wants to know, like I know a brand that still has that kit today, you can reach out to me via email. I'll be happy to answer that for you.
sounds great.
How's that? Okay.
All right, we have another question, I think. Here we go. What is the best way to provide support and reduce pressure point from O2 canister on the back of a wheelchair?
It should not be on the sling part of the seat. That's really the problem. So that's another thing to consider when you're starting to replace chairs, is the ones that have the brackets in the back that are not going to be in the way. They make different types of O2 holders today. There are other options. Those are things to consider when you're buying new equipment. You're going to have to look for a chair that's going to be able to accommodate that. But yeah, it's never good if it's digging into somebody's back. That should never be touching the patient.
What about the dementia residents who do not remember to lock their brakes and still have positioning needs? The 4-caster chairs would work great, but do not have the ability to put anti-rollback brakes on.
Yeah, again, that's something like when they're, again, I mean, I wish I had the magic answer for that while I was treating too. It's really kind of trial and error. Can you put a little tilt in there? And when I say that, I don't mean because we want to prevent rising. I'm thinking about having a little more comfort. Like the more comfortable you can get somebody and the more active you can make them, it's still not going to always, they're still going to get up. If they really want to get up, they're still going to try to get up, right? The best thing we can do is make them as comfortable as they can be and active as they can be while they're sitting to keep them from, or maybe try something with rocking, because that's another, sometimes that will take that thing for movement, that need for movement and restlessness. It's going to depend on the time of day too. There's so many variables, but the best we can do is with all of our options, try to create it the least, just like it's the least restrictive. We also want to make it the most safest. But I wish I had a magic wand.
It's a lot of trial and error. Yep. Can you go over the benefits of casters again?
Sure. So for someone who really has arthritic shoulders, that might not be able to propel with their arms at all, and has difficulty propelling a standard chair with their feet, sometimes it's difficult to get the chair to do what you want, depending on the chair. Casters are great for someone. They're easier. They're a lot easier to move with your feet if you've ever tried one. They're a lot easier to move with your feet, and I like to think of them for patients that do have a cognitive deficit, because again, we're not going to teach them how to propel a wheelchair if they have a cognitive deficit and they've never used one before they had dementia. So for a lot of people, it's a lot easier. But again, these are things like you can build in. It's not going to work for every patient, but if you have more tools and you have if you have bigger inventory to choose from and you make some more adjustable different options, it'll make it, you'll have other things to try. Or you could, manufacturers still let you trial chairs today, so that's another thing to consider.
Great. Where can I order super low wheelchair seat for short residents and high seat wheelchairs for a tall resident? I can answer that.
A lot of manufacturers, go ahead. Go ahead. You go ahead, Kelly.
Well, there's a lot of different vendors out there, and I would look to those that can either customize the wheelchair for you. A lot of times these are not stocked chairs. The super low or the super hemi height are chairs that are going to have to be special ordered. So those vendors that you work with that have the ability to access chairs that can be custom ordered, that's where I would start. The high back seat chairs are pretty accessible. So there's a lot of vendors out there that offer that. Now, if you need lower seat to floor heights on those high back, those are hard to come by, quite honestly. So again, that would be kind of I would again reach out to your preferred vendor and work with them to see what's in their portfolio and start there.
I have to interject that Broda definitely has those. So we have a lot of pedal chairs that have high backs, and we do have a lot of low seat to floor height options that start at 12 that go all the way up. So we have a lot of options.
Very true. What do you recommend placing under a resident who is sliding out of the wheelchair if Dyson shouldn't be used, who also can't have their leg rest on at all times due to cognitive impairment?
So again, if you can use Dyson underneath the cushion, you should not put it underneath the patient. So it depends on what their positioning problem is. Like, why are they sliding? Are they wilting during the day? Are they not? They might need a good posture and positioning cushion. They might need offloading. They might need all three. So again, you have to really take a look at the patient, get them on the mat and see what they sit like when they're on the mat and see what's causing them from sliding. And then again, of course, if it's behavioral, that's a whole other issue. If they don't need leg rest, again, low seat to floor height, because especially for patients that have cognitive impairments, a lot of times, I feel like a lot of them have like gravitational insecurity, especially if they're later stages. So if they can get their feet on the floor, that's when low seat to floor height is really important, so they get that proprioceptive input.
Great. think we have time for one more. And then the rest of the questions that are coming in, we certainly will answer them. We'll send out an email with the answers after the webinar today. What is the best way to secure a cushion in a wheelchair and prevent resident or cushion from sliding out from underneath them?
So the ones that have the strap in the back, or a lot of them today have the higher end, most higher end cushions either have the strap in the back or they have the ones with the Velcro, like the ones I was showing you before have that like heavy duty hook and eye Velcro. The only thing is you're going to have to put that on the seat of the chair when you do that, but they're not going to budge once you put them on the seat, especially that really strong industrial hook and eye. What do you call that stuff? I should know this. I'm an OT. Velcro.
Mm-hmm.
Velcro, the blessing and curse. So, yeah.
Yes, that is the truth. We will now be turning over to the product portion of the webinar. We hope that you can stick around and learn a little bit more about the Brenda Synthesis positioning chair and the Encore pedal chair. These are going to be linked back to a lot of the concepts you just learned. Thank you everyone for sticking around. I appreciate it. I have my friend Clay here to help me out in showcasing some of the products we're going to talk to today. The first one we're going to talk to is the Brenda Synthesis positioning chair. This is a great product for that more dependent resident that might have some involuntary movement. Maybe they need to be tilted in their chair at a certain degree for feeding, for a G-tube, for instance. Perhaps they're at high risk for falls. Really great chair to help out with some of those needs. The way this chair works is that it has a couple different options. It can tilt the axis of the seat all the way into this axle point, which is going to offload that pressure underneath Kelly. It's going to make sure that that pressure that's driving down in the IT area and the coccyx region is redistributed to like that lower back all the way through the hamstrings. It's going to help with securing him in the chair, making sure that he doesn't fall out if he is leaning forward or has any kind of spasticity. And that reclining mechanism is going to help with further positioning, opening up that back. When we open up the back, it's going to open up the organs really. If you crunch those organs, it's going to really compress your lungs. It's going to really compromise your digestion, your ability to breathe. So by opening up that back, it really helps to help that person be in a more suitable position for just function in general. The other thing to mention about the Synthesis that I really like is the choice that we're giving the resident. So the resident has a choice of what kind of upholstery they want to choose. So there's different colors, different designs. We have different frame colors for them to choose from. So it really brings it back to that person-centered care ability to allow that person to have something that's unique to them and what they like. And then more importantly, it has some great positioning. So we have these big pads here that help support those shoulders, or I can flip this big piece here to the lower part so I can support the torso area, and I can move this kind of up and down this track here. So it allows for easy adjustments to really make sure that it's fitting the right person in the right way. I'm going to go ahead and tilt you back, Clay. Here we go. So as you can see, as I tilt Clay back, I haven't compromised his central viewpoint of where the world around him. He can still have that conversation. Sometimes when you just recline the back, what we're doing is reclining that person and they're staring at the ceiling now. The tilt in the seat is going to offload that pressure, but also give him a good viewpoint of what's going on around him as well, so he can stay engaged. I can also, though, recline that back. So we're gonna go ahead and recline you a little bit here, opening up that back, getting him into a little bit better positioning for him, more comfortable. And especially if he's hunched over, this is gonna help really kind of keep him back and secure in that seat. And if I really want to do some additional positioning, maybe the person is very, very dependent, they're immobile, and I wanted to work on a lateral transfer from a bed to the chair itself. I can get this chair down into a stretcher bed position. So I'm just going to take you back a little bit here, work back. This is great for peri-care as well. So it really does have some great application when it comes to clinical services that this individual might need. Take you back up here. I won't leave you hanging. Another thing to mention about this particular model, the Synthesis, is that it has
what we call, or what Broda calls, the transport package, which allows for a WC19 rating, meaning I can take this chair and I can tether it into a moving medical vehicle without having to go through the process of a transfer, which is really great because that takes time. And then when we start talking about staff efficiencies, this chair is going to help mitigate some of that and allow for the chair to be safe for the individual to use and be tethered into that van or that medical transport. That is a separate package, and that has to be ordered at the same time as the chair. We have a separate item number for that. So just be aware that's not an aftermarket add-on. The chair I have over here now is going to be for that more mobile, independent, more agile resident. This is going to be an individual that still foot propels. I don't want to take that away from them. That really, I want to make sure that that person's still activating their lower body, really engaging in those muscles, creating muscle mass. We don't want to take that independence away from the individual. So this chair, as you can see, has a much lower seat to floor height, so that person can get a good heel strike as they're propelling around. The foot front riggings here can pop off and swing out of the way as well. This has a tilt in the seat, not a recline, but a tilt in the seat. This is because if someone's kind of hunched over and their foot propelling around, it's going to help keep them back into the chair, but not compromise that seat to floor height, so they can still move around. You have the choice of either high back, similar to what we see here with some lateral options, or you can order it with the head rest here, which is going to help with anyone that has kind of movement in their neck or lack of control in their head. And then what I like too about this is this has the rocking mechanism that I'm showing here. Think about your individuals that are part of your memory care programming, and someone maybe that's sundowning or gets agitated. This is going to be an individual that might really benefit from that feature because that rocking motion helps to calm the individual down. So great features on this. Again, similar options, lots of sizes and width and depth in the seat surface, as well as seat to floor height, and options in that upholstery and frame color on the Encore pedal chair here as well. If you have any further questions on either one of these models, as well as any product from the Broda line, for that matter, I'm here as your support. I'm here to jump on a call and have that conversation with you. Certainly your account manager is your immediate assistance for pricing and quoting and product information as well. So please reach out if you have questions. Otherwise, have a great day, and we'll see you next time.